VHA has an incentive to consider not only the health of veterans, but also the health of their system of care. Unlike most health systems, VHA cares for veterans over the entire life of the veteran. It has exceptional opportunities to research, collaborate, and strategically invest in innovations yielding both short and long-term value to its providers and patients. To speak more on delivering equitable care, please give a warm welcome to Dr. Ernest Moy, Executive Director of the VHA Office of Health Equity. Thank you.
Are you going to introduce Sonia? Oh, okay.
Hi, I'm Ernie Moy, and I think our actual first speaker today is Sonia, and so I'd like her to join me up here on the stage, and I will give remarks after she's done.
Thank you.
Can I rely on you to introduce yourself?
Good afternoon, everyone. My name is Sonia Elbow Timmon. Before I get started, I was asked to come and give a crisis to cure veteran story. But I want to start out by telling you that in September of 1989, I earned the right to call myself a United States Marine.
All right.
I will forever have that right. But like many of my veteran brothers and sisters, leaving active duty and transitioning to civilian life, something that appeared to be simple, really isn't. And for me, it was like a sliding slope. I am proud of my military service. There were things that I learned there that has helped me throughout my life. There were things that I learned there that worked when I was in active duty, but didn't serve a great purpose once I got out.
That's right.
One of those things was my inability to ask for help. You see, as a Marine, there was no retreat, no surrender. You got the job done, regardless. When I left military service and became a civilian, life for me changed drastically. I can say that when I first got out, I went to the VA hospital. At that time, the hospital I went to had a women's services, which was in the basement. And I remember someone had to guard the door in order for me to use the restrooms. The services that I needed could not be conducted in VA, so they sent me out into the community. I did not go back to the VA for another 17 years. In that 17 years, all kinds of things happened with my life as I was trying to gain my footing. Homelessness, single mom with children, job after job. I was having mental health challenges, biological challenges with my body, but I couldn't ask for help. The turning point was, as I was contemplating suicide, one of my daughters came to me and said, "Ma, I think I want to kill myself." As a Marine, as a mother, the only thing I knew to do is to go back. That was my last option. And on that fateful day, I dialed the Veterans Crisis Line. The person sat on the phone with me for 3.5 hours, instructed me to go to the nearest VA. I did what I was told, and when I walked into the VA mental health intake, the person talked to me for 15 minutes and handed me a prescription. Now, as a black woman, I can say mental health was not in my category as help. That was a system that I had learned not to trust. And to be honest, the only thing I knew about mental health at that moment was from what I saw on watching Jack Nicholson and One Flew Over the Cuckoo's Nest. single mom with children. I did not have time to be staring out no window. Quickly, I bolted for the door. But before I could open the door and leave, the provider said, wait. And she said, if this doesn't interest you, VA has all kinds of options. And I listened. And it was my ability to choose what I was going to use for my recovery process that kept me in VA. I went through all kind of programming in VA. I figured out if I went through voluntary services and volunteered at least 5 hours, I could get a meal. The canteen gave big meals. So what I didn't eat, I shared with the kids. Or I didn't eat and just gave it all to the kids. The homeless program. As a woman, I went through the homeless program. I was one of those people who received what they call the voucher for a home. It took me 4 tries. Why? Because they said a woman was more able to couch surf. But see, I'm a Marine, and I don't give up that easily. So I kept going and I kept going until I got the answer I was looking for. Not only did I use the homeless program services, as a volunteer, I began volunteering and working for the person who was the chief of what we call compensated work therapy. And I went through compensated work therapy. I went through trauma services to take care of what was happening to me mentally. And I can say when I went through trauma services, I was fortunate in that I was able to be in a group of all females. On the last day of that group, we were informed that that would be the last female group VA will have in trauma services at that VA. I was devastated. And in my mind, I said, that's not going to work. I know what it did for me to be among my peers. And I promised myself that if I ever got a job in VA, the first thing I would do is bring back women's programming. I have been working for VA since 2012 as a peer specialist. Now let's talk about the cure. I was fortunate to become a peer specialist because as a peer specialist, I am able to take my lived experience, translate that into working innovative practices to help my fellow sisters and brothers overcome whatever recovery journey they are working on. And I am proud to say, last week, October 20th, I was nominated and received the award for the National VA Peer Specialist of the Year. How and why did I receive this award? Because for every setback that I had, I worked with veterans tirelessly to create creative programming, to talk with clinical providers to make sure their care was equitable. But not just for me. I'm in the business of raising up an army. So not only did I learn as I went along, but I brought a whole slew of male and female veterans behind me. And together, we have created some innovative programming at our VA. One of those programs, Confident and Courageous Women's Programming, is on the verge of being piloted nationally across VA. The thing about making things equitable and creating programs, you cannot create a program if you do not involve the people who are the end users. In my world, do nothing for us without us. If VA is going to have sustainability, every stakeholder needs to be at the table from the beginning. No more, if we build it, they will come. Now we need to build together. That is my story from crisis to cure. And as we were taught in the Marines, pick them up, set them down, march from the waist down. As long as we keep moving in the right direction, we will continue to serve the men and women who our country has promised to serve. Thank you.
Wow, how can I beat that? Well, Sonia, I want to thank you for your service, and I want to tell you how proud I am to serve with you now in VA, trying to push things forward with the issue of health equity, because it's us working together that gets it done. We're not always there, we're not there, but we're trying to push ahead, right? March
Right.
from the waist down, is that it?
Right.
Okay, so let's do that together. I'm Ernie Moy, and it is my honor and my delight to moderate this session today. I am a general internist and the VHA Office of Health Equity Executive Director. And I am just thrilled to have this opportunity to talk about health equity because that's what my office does. I'm thrilled about the number of mentions that we've already had for health equity, and I'm thrilled that we have such wonderful people working on our side to promote health equity. My medical training, like many people, was involved many VAs. I worked in VA in Manhattan and Philadelphia, and my first job was at the Baltimore VA. And then I left to do other kinds of things, but mostly related to equity. So most of my career has been focused on doing research on health equity. My last 20 years was in federal service, and I came to VA 4.5 years ago because I got tired of talking and writing about health equity and wanted to do something about it. And I knew that this was the place that we could do something about it together. So I'm gonna start with some basics. I know we've been talking about health equity, but I thought I should give a definition. So what is health equity? And we define health equity as a state where every patient has the opportunity to achieve their best possible level of health. Then for us at VA, our job is to make sure that every veteran gets the supports they need to achieve that best possible level of health. And I use the word supports intentionally. It's not medical care, it's not mental health care, it's everything that a veteran needs. It's the health care, but as well as attention to all the different social services. And of course, VA is ideally positioned, I think, to address many of those social services. We can address issues with homelessness and food insecurity and education, just many things that people outside of VA cannot get. I think we are in the perfect position to be able to actually achieve this state of health equity. Health equity is important to VA for a number of reasons. First and foremost, every veteran earned their rights, their benefits. And so it's our job to make sure they get those benefits that they earned. Not most veterans, but every veteran. And so that's what health equity is about, making sure every veteran gets the supports they need to get to their best possible health state. The second reason is because when we step back and look at quality of care in VA, it's very good. So we're not struggling to improve the overall average quality in our system. Instead, we're working to try to make sure that that good quality care gets to everybody, and that the health outcomes that come from that good quality health care meets everyone's needs. And what we see is that in many VA medical centers, it's not that most people are not getting good quality care and achieving good quality health outcomes. Rather, they're getting good quality health care, but only some of them are achieving those good health outcomes. And for me, that's really important because it's not about redesigning fundamentally our healthcare system and how we're delivering healthcare. It's about taking what is working for one group of veterans and tweaking it and fine-tuning it and customizing it and making it culturally appropriate so that it works for all of our veterans. And fundamentally, this is a different way of doing things. And I think it's a more efficient way of doing things. We don't have to throw away our system and totally redesign it. We need to take what's good in our system and apply it better for those patients that are not achieving those good health outcomes from the good processes that we're delivering. I think the intersection between innovations and health equity really came to the fore during COVID. So during the height of COVID, we had to change everything we did, but VA was really well positioned. We had a long history of doing telehealth. We had the VA Video Connect system operational. We had our providers well trained to deliver those services. And in fact, throughout the pandemic, the veterans were able to achieve primary care and mental health services at comparable rates to before the pandemic. There was really never a drop in the service delivery for those particular kinds of services. We were able to substitute virtual services for face-to-face services so that the numbers continued to be good. People continued to be seen. Moreover, when we look at the information, underserved veterans received care just as well as more advantaged veterans. So older, minority, disabled, rural, and even homeless veterans were able to access telehealth services at rates that were comparable to more advantaged veterans. However, there was an important distinction, and that is the way they accessed telehealth services differed. So older, minority, and rural veterans are more likely to use services on a telephone and less likely to use services on an internet-connected device, which we think is probably the best way to receive those services. And this was in part related to poor access to bandwidth. And so at one level, telehealth worked. We were able to give access to all of our services. All of our veterans were able to access the services that they needed, but the quality of those services varied depending on who you were. It was worse for some groups than it is for other groups. And in response, VA adapted. So, we're changing, and so we adapt. And one of the things we did was we increased attention to underserved veterans and sought to identify and meet those unmet information technology needs. We started digital divide consults, and these enabled any VA staff to identify a veteran who's having an IT issue to refer them for a digital divide consult and have those needs met. Interventions included lending tablets to veterans, providing discounted internet connections and data charges, and training veterans to use the VA Video Connect systems. And the digital divide consults reached and helped tens of thousands of veterans. Yet we suspected that we didn't get to everyone, and we started looking more actively for veterans that we were missing. As part of our social determinants of health screening, we included questions about barriers to telehealth, about digital divide issues, instead of waiting for staff to identify people that were having issues. And when we did this, we found very high rates of unmet needs for telehealth, much higher than we had thought, much higher than people that were being referred for digital divide consults. For instance, of veterans referred to social work, almost all of them have some kind of social determinants of health issue. Digital divide was actually the #1 problem that they were having, even if they were going for housing problems or food problems or employment problems. And when we looked at veterans who were receiving primary care in rural clinics, about half of them reported that they were having digital divide issues. This was really the area that we realized that we needed to focus on if we were going to deliver telehealth more evenly to all of our veterans. So on one hand, we got the people through the pandemic. On the other hand, we didn't get to everyone as well. And that's, for me, one of the big local challenges. As we start this discussion about equity and innovation, I want to learn what we could have done better. What could we have done so that we developed and deployed our IT so that we never had disparities in the first place, that we could prevent them? And more generally, how can we intentionally build equity into IT so that it's always there, always in the front of people's minds? And even better yet, how can we innovate to directly support the things that we need to achieve health equity? Things like building that diverse and inclusive workforce and environment where people feel good about coming and being their authentic selves. What IT can we put into place? What innovations can we put in place to foster that kind of environment? What can we do to better identify social determinants of health issues and address them and match veterans with the solutions that exist out there, but they just don't know that they're? How can we connect them better to those particular interventions? And lastly, how can we work with our providers to identify the problems with quality that are occurring out there and make sure that the good processes of care that we deliver achieve good outcomes for every veteran? I'm looking to this expert panel here to help me understand this and hopefully for this group to also do some learning. And I would like to invite them to join me here up on the stage. And I'm going to ask each of our panelists to introduce themselves. Click to start.
Good afternoon. I am Captain Wanda Finch. I am a member of the United States Public Health Service Commission Corps. I'm a Deputy Director at the Center for Medicare and Medicaid Services, Office of Minority Health.
Good afternoon. My name is Adamika Arthur. I'm the CEO and Executive Director of a nonprofit called Health Tech for Medicaid. A little self-explanatory. But we essentially are a convening body that brings together payers, providers, policymakers, entrepreneurs, investors, advocates, but most importantly, people on Medicaid. There's 87.5 million of them in the US, along with their families and ultimately our communities.
Hi, good afternoon. Silas Buchanan. I'm with the Institute for eHealth Equity. eHealth Equity, as the name infers, we're concerned about an exacerbation of health disparities because of technology. So we spend a lot of time working with underserved communities and communities of color, raising their literacy around the benefits of adopting and utilizing technology to improve health outcomes for themselves, families, and communities writ large on one side. On the other side, it's critically important that we work with the ideators and innovators of health tech solutions to assure that they're spinning things up in culturally appropriate ways. We do a lot less consulting these days and are actually building things. So we got a spot of funding from Morehouse School of Medicine to stand up an ecosystem designed for the leaders of faith and community-based organizations. We're starting with faith-based. Our healthministry.com is designed to put the leaders of these faith-based organizations together and keep them together. These are folks that are known, like, loved, and trusted by community members and historically embedded in our community. So happy to be here and very inspired by what you had to say, Sonia.
Yeah, great.
So, well, welcome. My first question is for you, Sonia. Leaning on your care delivery experience as a veteran patient expert as well as a mental health specialist, how do you make the case to healthcare leaders that accounting for health equity principles in the design of innovative clinical practices and the deployment of digital health solutions is an important investment?
Well, I can say it's an important investment because we have to meet people where they are. And we have to know that the veterans that we're seeing are not just veterans. They are mothers, they are fathers, they have families, they have other responsibilities. And we also need to look at being more flexible. People have things that happen outside of 8 to 4:30. So making sure that our providers are available, making sure that the patients can actually reach us when they need the services, using technology. That was a really big piece for when the pandemic hit. But we didn't look at the fact that all these mothers who were home also had children that were home and was doing education. So how do we incorporate all of that? And my thing is, again, we have to talk to the end user and let them tell us what it is that they need. And then you build a system to help.
Yeah, I guess if the end user doesn't use the product, it just sits on a shelf.
Wasting money.
There you go. Adamika, this one's for you. So many healthcare organizations have embraced technology and moved forward with the adoption of standards, tools, and processes that don't explicitly take into account the consequences on factors that impact health equity. How do organizations start from the beginning in the design phase of a strategic innovation plan to practice equity by design?
All right, well, I'm going to just out myself first. So I'm an epidemiologist by training, started my career in public health, and turned hospital leader because of the expansion of Medicaid in the state of California in 2005. So I was actively a part of the expansion of Medicaid and the $180 million that got deployed within the state of California, which is the fundamental legislation that helped us expand it through the ACA. So I'm outing myself because I've been in many different spaces, and having run hospitals for 15 years, grappled with this a lot. and I preach today equitable and inclusive design deeply in my bones. So one of the things I will say is a framework that has really, we've spent a lot of time at Health Tech for Medicaid educating lots of different systems on. So systems and institutions by nature have some challenges. We inherently have biases. We have structures that have been systemically and historically challenging people. We built these systems to work, and now that they work, people are like, why are they working like this? Well, they were built like that 40 years ago, 50 years ago, 100 years ago. So I start with the four, like who are we designing for, right? And the with and by, right? Who are we designing with, and who is designing? So the first thing is, the first step hospital systems and systems in general go to is they want to go to a consulting agency and they want to bring in somebody who are designers. The first thing is to dispel the myth. We are all designers. We are. All of us are designers of some way, shape, and form. We design some pieces of their life, of our own lives, right? So you were talking about earlier, being at home. I learned to design lesson plans and all sorts of meal plans. I was a short order cook during COVID. I designed all sorts of things that I have no competency or skills besides being a loving mother to do, right? So that's the first myth we have to dispel. Who can design? We all are designers. And if we lay that playing field first, then it's who are we designing for? That's a really interesting thing. And we can evoke different methodologies to do that, but one is actually through co-design. And that is something that's really challenging in institutions and systems because the first thing they see is dollar signs. Well, I will tell you those dollar signs still come when you work with the consulting agency and they do 10 million change orders, right? Because I've been on the other side of receiving those bills, right? If we design directly with the community in which we're trying to design for, the for becomes a broader for. We're designing together, right? And then how we go about designing. There are ways in which you co-design by shifting power, by looking at an asset structure. And I can give you all sorts of different frames. This is not a design thinking course, but one of the things we often do is we don't think from an asset lens. We say, oh, well, this is what we want and they need this. We need to actually have forms where we understand what everyone needs, step back and figure out what are our resources to do that. So instead of thinking from a deficient mindset, which is often the way that every time people talk about human-centered design, I love human-centered design. And there are incredible organizations and companies that have been doing human-centered design for a long time. The new frame is actually equity-centered design because human-centered design by nature was biased and flawed, right? Because it was never developed for everyone to be designers. And so I think that goes back to how systems can start. It is really reshaping and reframing our thinking around how you design well. And then I will tell you, the way that we design our emergency rooms, our triage spaces, can be both beneficial to the system and beneficial to the community in which people live, and as that community grows and changes. So that's the other piece we often haven't thought a lot about, is the social, political, economic, and environmental adjustments and changes that happen not at this point in time, but over years to come.
Can I chime in real quick? I can't tell you how many church basements I've been in, right? Where the community outreach or engagement person shows up because they know by zip code where the non-compliant diabetics are,
Yes.
right? And so they show up with pre-printed materials and say, hey, can you stick this in the church bulletin, right? And the church leader will graciously take it, and then the person leaves, and it goes in the trash, right?
Yeah,
because
sure.
it's not at all reflective of the community. They're not proud of it. Connect, convene, collaborate, and co-create, right, is critically important. And just that little step before you go to print, get the input, right? And now you have a more equitable partner when you begin to drive engagement to community.
And I think a great example of that, so when I was a hospital leader, we often talked about medical transportation, right? How do we get our most vulnerable folks to show up? Now, interesting, your frequent flyers, they can show up every day. In fact, I know who they were, what kind of sandwich they liked. I know all sorts of things about, I knew who had kids and who didn't, who went to, what day the the food bank was, because they weren't there that day, but they were there, the other days. The thing that's really interesting is, companies, tech companies would come in and beat down our door and finally find a little sliver of time that I didn't have on my calendar. We have this incredible app. And I finally got to the place where I was like, you need to find a local church. Because Jerome, who drives the church van, picks up, 150 elderly women, and men and, non-binary people every Sunday. You need to employ, every Uber needs to employ Jerome, right? Because you will get more information and they will get to their appointment. Because oftentimes there is trust. So change only moves as fast as our vehicle of trust. Mm-hmm. Trust is really critical, whether you're tech enabling something or not, right? Something either goes into the trash or you create this flashy app and you hire a bunch of people. You're not then creating a workforce pathway for people to get out of the cycle of poverty. You're not then creating a stable economic ecosystem, because your company will end up going out of business after that first or second venture check has gone away, right? And ultimately, hospital leaders then start to think of you as just yet another app company, which becomes true.
So Wanda, I wanted to drag you into the conversation.
Yes, of
So we're
course.
talking about, well, this is what things should be, but this is not where we're at. So what are the challenges that you see out there that are preventing this good approach from being used to reduce these equity problems that we see?
Certainly, and I want to thank Sonia for the courage of sharing her story and talking about the needs that she's experienced and what she's working on now. So I think from a CMS perspective, the challenges that we see really rest in data. If we have the right data, it can tell us who needs what, where they are, and give us a window of opportunity to try and address those unique issues specific to those individuals or groups or communities. And so one of the things that we've done at CMS is we've developed a CMS framework for health equity. And it is just that. It's a framework. It allows community-based organizations, faith-based organizations, health systems to use that as a roadmap in trying to understand what are the priorities, how do we go through looking at them and addressing some of those needs. With the data piece, we are working with some of our other federal partners to look at how we can expand the data collection, really understand social determinants of health data, so that because we realize that individuals don't just come to see their physician just to see their physician. There's always other underlying issues that are related to SDOH. And so we've also worked with the Gravity Project, a public-private partnership, to really look more at some of the social determinants of health, and particularly in the use of Z codes, the SPADES, data assessment elements, and looking at ICD-10 CM codes as well to really help understand that and paint that picture so that we have a better sense of who are we serving, so that we can try and understand where those gaps exist, whether it's language gaps, is it socioeconomic, is it transportation, and really try to hone in on how to best address those needs.
So I think that's one series of challenges that we need to overcome to get where we want to go. Silas is going to ask you, do you face different kinds of challenges in trying to get inclusive, culturally competent strategies for pushing this work forward? Is it just data, or are there other problems too?
Well, data is always a problem, right? The collection of data, right, is an issue, but equally important is where and how that data is shared, right? So I live in Cleveland. I can take you to wherever anybody lives, because it's pretty much the same in almost any city, but I'll use Cleveland as an example. Lined up outside of HUD offices right now, I guarantee you, whoever has the NIH, Pcori, Robert Wood Johnson Foundation grant of the moment is knocking on a community's door through the HUD office. So you'll see the Cleveland Clinic there, UH, Metro Health, Cleveland State, Case, they're all lined up, and they want data. And what are they offering in return, right? A ham sandwich, right? We'll buy you lunch, for your data, and it has, outsized value. So that's a offensive if you're not working through those trust brokers that are known like Love and Trusted in communities and historically embedded in communities. That's kind of the front hand of that. The back hand of the slap, however, if I can frame it this way, is the lack of sharing of data, right? So now data's collected, right, about our communities, but it's not shared back in a lay format that's usable by community members, right? So the 501c3s that are historically embedded in these communities that we're talking about are stuck at $5,000 and $10,000 funding levels from the Cleveland Foundation, Atlanta Foundation, Columbus Foundation, New York Foundation, because they don't have quantitative, qualitative data around their own communities, even though whoever has the NIH grant of the moment has knocked on their door and said, hey, help us to extract this data from your own communities. The system is just so inequitable, right? And it drives distrust. So we're broken in that way. And so we're looking for ways to correct that.
I was just going to say, we had a backdoor, Sonia and I had the lovely example of having a backdoor conversation before we got in here. These systems were designed, data systems. As an epidemiologist, people are always like, oh, you're an epidemiologist? Yes, there are Black epidemiologists. There's a few of us out there. We actually went to school like everybody else. My family was like, what are you going to be and how long are you going to be in school to be what? But disaggregated data is really important. How we do reciprocity around data. A ham sandwich may work for some, may not work for others. Investing in the local community center may work for others. Paying for my kids to go to summer camp may work for others. Like, I think looking at what reciprocity is, and we often look at it in a deficit mechanism, not an asset mechanism, because we give benefits and resources and rewards to lots of folks. They're just accepted. But what I was going back to, the conversation we were having, because our frames have always been traditionally white-centered, I'm just going to call it what it is, what happens is then when we come back and say, we'd like to gather around the table, or we'd like to tell you that AI, by nature, is biased, then it's either a confrontation, not because you've been confrontational, but one, we're not used to having these conversations. And one of the things that is necessary in equitable and inclusive design work is to talk about inclusion and exclusion criteria, which means we have to have uncomfortable conversations. Because if we say something like, look, Silas, we're developing a program in Cleveland for our top 1%. We are targeting women who don't work traditionally outside of the home, and they make over $175,000. That, shockingly enough, is an acceptable conversation for us to be having, right? For whatever reason. But if we say, Silas, we're going to go into Cleveland, and we're actually going to go outside of Cleveland. We're going to go to Elyria, Ohio. And we are going to look at women and non-binary individuals who are 450% below the federal poverty level. And that conversation looks different. We have to be able to be clear about inclusion and exclusion. It's also the reason why equity, I mean, you've spent your whole career doing health equity work, and I would argue I have too. People today in the stage have misused equity and equality. Equity is not equality. And if we don't get and equity is also not money in this context. I mean, it is another context. But we have to actually define what we're trying to do. Because now that CMS has done a plan, and it's a little sexier now, they forget about those of us who've been doing this work tirelessly, like you, for the last 30 years. We're unicorns, right? But there's folks like us who've been doing this work for this long. Use us as collaborators. Don't try to co-opt our current system by saying because CMS has this framework, because this is the way it works in this country, now there's some money out there, and they tumble and run over Silas and myself, right? And they want to create their own stage instead of us working together. That, by nature, is not equitable. So, I mean, I think we just have to call a spade as well. Sorry, I'm like co-opting your talk here.
I was going to ask Wanda. So now,
Yes.
thinking about solutions, so these are the problems. Do you know of good solutions or good models for overcoming some of these issues that you've seen in play?
Well, there's a couple of things, and I want to be very clear. Our framework does not cost anything. So
No.
I just want to say that.
No. When you have a framework, what happens is those folks who do have cash
Who
say,
have
now
cash.
use this framework to do your work.
Yes.
But the fundamentals in that framework, many of us have been using as competencies and principles for years.
And the one thing to take away, our office has a TA program. We have a technical assistance program. So if you pick up something on our CMS OMH website and you have questions about it, you can call us, you can email us. We're there to help at no cost. So, and that's been an enduring part of what we do. So that's one of the solutions. The other piece of this is health literacy as well. I mean, how many of us in here were born thinking about equity, right? Probably didn't hear about it until maybe you got to grad school, unless you were industrious enough, maybe you picked it up along the way, you know, because of life experiences. And so there's the hard knocks of life, right? Yes, right. And she said, or lived it, so lived
of us lived it,
experience,
yeah.
that's right. But I think that there is a conversation here about health literacy, education that goes along with healthcare. I think the last panel talked about some similar kinds of things, and so we do have a resource that is available for anyone. We call it Coverage to Care, which is a roadmap that helps anyone. You don't have to be a civilian. You can be VA, you can be DOD, you know, you can come from any healthcare system. You can pick that up, and it will help you walk through the steps. How to have a conversation with your doctor. What are the hard questions you need to ask? Don't just go in and, you know, do the vitals. Walk away with something that's going to be meaningful for you. And so that Coverage to Care, it's a suite of products. We have one for behavioral health as well that also helps to guide that discussion. And again, they become roadmaps to help individuals kind of navigate this whole process. And the final thing that we are doing to help solve some of these challenges, we continue to make a concerted effort every single day to work with our partners in CMS, to work with others across the federal government, including SAMHSA and FDA and CDC. And I'm burgeoning looking at what we can possibly do with DOD and VA, you know, through an equity lens. But it's a little tricky because of where I sit in the agency. But those are just some examples of solutions.
I was just going to say, health literacy is one side, right, of the coin, right? And it's always the thing that's focused on, right? We've got to improve health literacy at the community. We've got to improve their health literacy. Well, let's also improve the cultural competency, okay, of the physicians. You know, right outside this door, I met at a table. They've got a virtual reality setup there, right? And it's teaching clinicians about gun safety. And I said, no, is this for vets, for patients? They said, no, this is for clinicians. So they can learn about gun safety so they can better treat or address gun issues in the home. The exact same thing could happen, right, around cultural competency. I won't tell a long story, it'll be a 30-second story, but a friend of mine, or someone I met recently, I won't call him a friend just yet, I'll call him a colleague, right, went through elementary school, middle school, high school. He had 4 people of color in his class, went to med school, graduated, and his residency, he had 4 people of color throughout his academic career, right? His residency was in Harlem, right? He has no cultural competency. He doesn't know how, so it's hampering his ability to be a good physician because he doesn't have that training. So literacy is one side, but I also want to focus on cultural competency and improving that on the clinician side.
And one other piece of health literacy is tech literacy.
Yes.
Right? Because we often forget about the bridge between not only having the conversation in the clinician's office, which oftentimes people can't even hear, because you're telling them something that's even challenging, confusing, et cetera. But they go home and they consult, you know, a whole myriad of technical outlets. I'm not even going to name one because there's so many, right? And they get false information, true information, any information. And so the tech literacy is also the other thing. And that's also, in some ways, a way that we can actually reinforce the health equity, right? But we often really focus a lot on health literacy, or healthy literacy is what I hope it is, right? But we need to really think about what is the bridge between health literacy and tech literacy in a culturally competent way, but also in a gradual way too, right? Because cultural competency doesn't just happen by dropping you into Harlem, right? And tech literacy doesn't just drop, you drop a computer into your home and all of a sudden you're tech literate.
There's two other things I want to add here, and it dawned on me as you were talking about the cultural competence. There's also language barriers. We see it a lot in, I think, the civilian sector. I'm not sure how pervasive it may be with DOD and Veterans Affairs, but we know that from COVID, that Black and brown communities suffered the worst. By design. And so when you think about language access, we do need to be smart about ensuring that whatever it is we're doing, that it's reaching the people who need it the most, when they need it, anytime, anywhere, any place. And the other piece is accessibility and disability. Often that community is often forgot. And I want to ensure that when we're thinking about health systems and how to reach the people who need it the most, that we're thinking about all of the different doors and windows that we need to be looking through to ensure that we're reaching those who are most needy. And please don't forget those who are living with disabilities.
I think that's important, but the biggest piece of that is the intersectionality. Most of us do not live in one box or just can check one box. I will tell you, as an epidemiologist, and most people at CDC and any other agencies know, I get so irritated when I see race and ethnicity on the same slide. Now, I'm not saying I fall into and understand all these constructs that were developed around race in this country in 1977 due to the OMB, but that's what we have in this country. You cannot, by nature, conflate apples and oranges together on a slide. And if you go home, and every presentation will conflate race and ethnicity, when they do that, they violate disaggregating people, meaning that in order for race and ethnicity to be on the same slide, and it's often, I live in California, so it's often, Latino or Hispanic, and then the race would be, white, Black, Asian, indigenous, fine. But when you put them on the same slide, you've got to pull people out of race categories to do that. So they lose sight of the fact that there are many Hispanics and Latin individuals in this country whose race identifies with Black, whose race identifies with white, whose race identifies with not no race, not checked. And so I think that it goes back to using our system. We have systems in this country. I'm not saying they're great. They were designed way before I got here. A lot of the problems we have is because whoever designed those systems designed them. But then let's use the rules of those systems to fix our problems. So it's intersectionality that we have to think about. We are right. We have to think about gender. We got to think about race, and we got to think about ethnicity, and we got to think about whether or not you're housed and what your definition of housed is. Because couch surfing to many people is housed. You got a roof over your head, right? So you've got to understand what it requires conversation, which is why I'm a huge fan of doing that sort of work. But to not lose sight of the fact that there are intersectionalities, and that is why disaggregated data is so important, because I can't even check one box. I got a million boxes to check.
And we have to,
okay, no, please go.
I'm sorry, but we have to also look at, with this cultural competence piece, we have to have an employed workforce that's indicative of the people they are serving.
Yep.
That creates, when that doesn't happen, that only creates a wider divide when it comes to trust.
Yep.
I gotta tell you.
And I don't know how many times as a liaison I have had to have difficult conversations with people who should know better, who are serving regarding something culturally wrong that happened and why this veteran was affected that way.
Yep.
So we have to really make a call for the front line.
The messenger many times is more important than the message.
But we also need to look at the governance. The governance needs to also be diverse and equitable. You know, we need to look at the outcomes, right? So it's not just the front line, because we're real comfortable in this country throwing people in the front line who may not get paid as much. We need the C-suite to be diverse, but we most certainly need the governance to also be diverse. Because if it's unculturally competent up here, it
Oh my gosh.
trickles through the entire organization. And we focus on the front line. We're like, oh yeah, we can do that. We can hire people to, well, let's focus on all of the layers in which we have to actually improve inclusive and equitable design of our system.
We talk about
Thank you
political
for saying
determinants of health, or social determinants of health all the time, but we can't really have that conversation without talking about political determinants of health.
You're right about that.
Which city council members voted to stop the bus from running in this neighborhood so I can't catch the bus to make it to my doctor's appointment? Very well said. But
Wanted to ask our controllers, do we have time for questions from anybody? Okay, so we can actually take questions from the audience.
Hi, Scott Wiltz, similar. My boss right now is shaking in his boots because he never knows what I'm going to say. So one thing in the spirit of calling a spade, you know, it's often said, particularly in the United States, you know, money talks and you know what walks. But I think what we're seeing more and more in the last several years is more so than money, it's about power and people trying to hold on to power. And I see the numbers change, but on one of the slides this morning is sort of the consistent thing of there's how much money would be spent on taking care of minority patients, and then the point at which minorities altogether become the majority. And so my question is, how do we impact this ahead of time where the people in control view it as you're taking from me, like it's a zero-sum game, and there's only so much pie? And how do we make some sort of tangible, effective change with the political determinants of health? I think that's a fantastic way to phrase it. Yeah. Because right now, honestly, it seems paralyzing.
So this is why many of us go to work every day. This is why Silas and I co-conspire every single day. This is why I left a very highly paying job running systems and being a CEO of a system to literally fight these issues daily, right? The reality is we have to have representation and at least a voice. So the reality is if there's no voice in the room, then how are we going to cede power? You actually cannot cede power. And it is ceding power. Let me be really clear with everyone in this room. We can't pull up a folding chair to the table. That is not going to help solve our systematic and institutional challenges in this country. Having everyone sit around the table is beautiful and nice, but there's not enough food to go around. I don't know what family y'all came from, but there's not enough. We actually have to change the seats. And the issue is governance. The issue is governance at every single level, right? So that's why when I work with health tech companies, I often say, how many individuals on Medicaid do you hire? It's great that you have a product that is serving Medicaid. Who are you hiring to get them out of the cycle of poverty, right? Because otherwise, we're not helping our systems change. We all have to move a few steps in a direction. So I think it's governance. I think it's taking the rules of the current system that we have and realizing we cannot demolish them, but we can challenge them collectively. Using data in an appropriate way, because we have seen how we can use data in an inappropriate way, right? With competencies and standards, and co-conspire and collaborate with others. Don't try to do everything on your own.
No, the community has to also, and that's so well said, I hope you guys can hear me okay, but as opposed to a seat at the table, the community has to become the table, right? And there's enough talent and technology right now for the community to actually become the table, right? So the ecosystems that we build, it's undergirded with synchronous and asynchronous meeting software that allows us to connect, convene, collaborate, and co-create with community members. The pastor can't meet at 10 a.m. on a Zoom, but can you review this material at 3 o'clock in the afternoon, 7 p.m. or 3 a.m. when you get home? We can then create collateral material from that, and now you're an equitable partner and you're written into the budget, by the way, and now we get to leverage your social media channels as a influential person at the community to reach community members. Equity has got to be baked in every step of the way.
Yep.
Well, I think we're out of time, so I wanted to thank our panel for this wonderful discussion. And maybe if the panel is willing to answer questions, maybe at the back of the
Sure.
conference room, if
Sure.
people have them. So to help me thank this panel, it was great. Thanks a lot.